Hey guys, welcome back to Job Study Smart Fun for part 5 of Pediatrics. In this PDF now you guys will notice that it's almost everything is written already because I'm basically shooting this video again. I had recorded in 1.5 hour session and basically there was some, the file got corrupted and the video got distorted, so I had to do it all over again. But anyway, shit happens, you have to move on, right? So let's have another enthusiastic session. Let's make sure that we will understand about a good amount of stuff regarding milestones, regarding respiratory system, regarding pediatric emergencies and much more. All right. So first thing which we're going to talk about is, guys, developmental milestones. In your milestones, guys, you need to know that you'll have around just a second. Yes. Okay. So then in the milestones, you need to remember 4 main domains, guys. Okay. One is going to be gross, one is going to be fine, one is going to be your language, and another one is going to be social. Okay. So gross, fine motor, and then language and social. These are the 4 main domains you need to know. Now in this, you need to remember at what month, what milestone is there. If this milestone does not occur usually more than +1, even after 1 month beyond the time period given, then that will be considered as delayed in the milestone. First, we're going to talk about gross. Now the gross, guys, you need to remember what is the rule. You have to remember the rule is going to be cephalocordal. What cephalocordal I mean is whatever movement or development in the milestones are, it is going to start from the head development and then going downwards to the toe. So head, then neck, then trunk, and then the pelvis, and then the foot at the end. Okay, so starting with by the 3rd month, remember guys, in 3rd month first is going to be head control, head and neck control by 3rd month. 4th month will be your trunk control, so the baby will start rolling over by 4th month. 6th month, guys, the baby will sit with support. Sit with support, which means is tripod position. What is tripod position, guys? This is tripod position. So tripod position is sit with support by 6th month. So always remember, first you will sit or do anything, any function with support, and then without support. So by 6th month, what are you going to do? Sit with support. By 8th month, now you will sit without support. Along with that, another function will be crawling. 10th month, now you will stand with support, and another function will be creeping. Now, what is the difference between crawling and creeping, guys? See over here, the first image which shows is crawling when the body is in contact with the ground and the baby is trying to move. That is crawling. When does it start, guys? By 8th month. And by 10th month, you will see something which is creeping. Creeping is when you use all the 4 limbs to move. That is creeping. So this is done by 10th. What is by 10th? You will now stand with support. So 12th will be stand without support. Along with that, now you will start walking with support. As I said you, the rule is always with support you will work first and then without support. So by 12 months you find out the baby is standing without support, and with support he is able to walk. The next thing you need to know, by 15th month, very important PYQ is that the baby starts walking independently. Okay, the baby starts walking independently by 15th month. By 18th month, the baby is able to run, and by 2 years, now the baby is able to climb the stairs. Now, as an adult, you see how do you walk? You walk by one foot at one step, then the other. But at two years of age, what they're going to do is they're going to have double step climbing of the stairs. Means both of the foot will be there. Then it's like jumping basically, right? So 2 foot, 2 foot, 2 foot. That is going to be done when? By 2 years of age. By 3 years of age, what you will see is now they're going to do single step walk, but this time in the upward direction, because it is much more easier for them to walk 1 step at a time, but in the upward direction. And by 4 years of age, they are going to go single step, this time downward direction. So remember, 2 years of age, what they're going to do? They're going to walk with 2 foot up, up, up. By 3 years, 1 foot, 1 foot, 1 foot, but up. 4 years, 1 foot, 1 foot, 1 foot, but down. So this is your gross motor milestone you need to remember. Another feature you have to remember is 3 for 3 years, and 3 years the baby will be able to drive a tricycle. This is another PYQ. By 3 years of age, this is a gross motor, the baby is able to drive a tricycle. And if they ask you when does the baby or when does a child hop, that will be by 4 years of age. How do you remember this? If you see, if anyone is hopping like one leg like this, it looks like number 4. So you can remember it this way. Hopping is achieved at which age? By 4 years of age. So this is your gross motor the milestones. Next thing we're going to talk about is fine motor. Fine motor also has another rule is always you will go with the order as proximal to distal. In fine motor, we are always seeing the movements of the hand. So with respect to palm and with respect to fingers, what is more proximal, guys? What is proximal? Proximal means anything which is close to our body. So our palm is much more closer than the fingers, right? If you see like this. So first will be the development of the palm, and then will be the development of the fingers. First 3 months there will be no fine motor milestones. Why? Because of the palmar grasp reflex, the hands are always going to be something like this. Only after the 4th month you will find some findings. The first by 4th month you will see is bidextrous grip. What is bidextrous grip is the baby will be able to hold any object with both of their hands. That is your bidextrous grasp. After that, on 6th month, the baby will have unidextrous grasp. The baby will be able to transport one object from one hand to the another, and he or she will have immature palmar grasp reflex. Now, what is immature palmar grasp reflex, guys? If the baby is able to hold from the palmar side, see, this is my hand, the thumb is towards the radial side, and the little finger is towards the ulnar side. So if the baby is able to hold it from the ulnar side, this is your immature. Mature is when he or she will be able to hold it from the radial side. So remember, by 6th month there are 3 fine motor milestone achievements. One is unidextrous grasp, other is able to transport one object from one hand to the another. 3 is immature palmar grasp. Now after immature, guys, will come obviously mature. So 8th month you will have mature palmar grasp, also known as radial grasp. By 10th month, now you'll have immature pincer grasp. What is pincer, guys? Is when you will be able to hold the object in between the 2 fingers like this. That is immature. Mature is when they will be able to hold it by the tips of the fingers. Immature is when you're able to do by side, and mature is when you're able to hold it like this by the tip. Okay, that is by 12th month. By 15th month, you will see that baby is able to do scrabble. By 15th month, the baby is able to scrabble. By 18th to 2 years of age, they will be able to draw a straight line. Okay, by 18 to 2 years of age, the baby will be able to draw a straight line. Now, one thing what I want you guys to do remember is over here now we're going to talk about the shapes, which are very important. So remember, there is a period at each period a different shape a child will be able to draw. So how do I remember this? Is by remembering our human body as a shape. Remember, circle as our head, then around the neck you will have a necklace, in which the necklace will be either a cross or a plus sign. Our trunk will be a square, pelvis will be a triangle, and the legs will be either rhomboid or diamond shape. Okay, so remember the circle, which will be the circle, by what time a child will be able to draw a circle is, look at the ears, they look like 3, so they will develop by 3 years of age. Okay, then if you see the neck, there is a necklace which is having a cross. This cross can either be a cross or a plus, and if they'll ask you when can a child draw a cross or a plus, that will be by 4 years of age. A baby is able to draw a square by 4.5 years of age. A baby is able to draw a triangle by 5 years of age, and a baby is able to draw a diamond or a rhomboid by 6 years of age. Okay, this is very important. Circle 3 years, necklace or like plus sign or cross sign will be 4 years, square is going to be 4.5 years, triangle is going to be 5 years, and diamond or rhomboid is going to be 6 years. All right. Now, one thing which you need to know, another feature is handiness. Like example, I am right-handy. So a patient develops right-handy or left-handedness by 3 years of age. Okay, talking about dressing. Now a baby is able to dress himself with support and without support. You need to know that is very important. A baby is independently able to dress or undress himself by 5 years of age. If they ask you dressing with support, the baby is able to undress himself by 2 years of age, and dressing with support by 3 years of age. That will be dressing. See over here, baby is able to dress completely without support by 5 years of age, and the baby is able to dress with support by 3 years of age, and undress with support by 2 years of age. Okay, now 2 domains are done. Let's talk about the language domain. The first, again this is the same, mostly it is starting by 3 months only. So remember, by 3 months the first things which the first sound which a baby brings out is a cooing type sound. Coo coo, they do like that, right? After that, by 6 months they're able to do a monosyllable, that is like ma, pa. By 9 months it is going to be a bisyllable, that is mama, papa. By 12 months it is going to be just split 12 months, like 1 to 2 words. Okay, 1 and 2 is right, so the baby is able to have 1 to 2 words. By 15 months baby will be able to have a jagran speech. What is a Jaggran speech? It is like baby is speaking something but you're not able to comprehend, like that. So they're just trying to speak something but you're not able to understand. That is Jaggran speech. What time? 15 months. Remember what is there for 15 months in case of gross? That was walking independently. While what is there in 5 months ka gross? 15 months was you were able to scribble. That was in fine, right? So like this, you have to just make a table and then you will be able to differentiate it like this, because the questions only will come like this. Like in gross milestone, they will show maybe on 15 month a baby was able to walk nicely, and in case of fine, baby was able to scribble, and in case of language, there was speech which was uncomprehensive, like that. So like that, you have to understand, okay, the baby is right now at 15 months old. Okay, by 18 months, again split 18, 10 to 18 words they will be able to speak. By 2 years, 2 word sentences or 100 words. By 3 years, the baby will be able to distinguish these 3 things. They'll be able to distinguish name, they'll be able to distinguish gender, and they will be also able to distinguish the age. They'll know, okay, what's your name, how old are you, how old am I, whether I am like a boy or a girl, like that, they will be able to distinguish. Okay, by 4 years, they'll be able to say a story or a rhyme. Okay, that is your language. 3 months cooing, 6 months monosyllable, 9 months bisyllable, 1 year 1 to 2 words, 15 months Jaggran speech, 18 months 10 to 18 words, 2 years of age 2 word sentences or 100 words, while as 3 years they'll be able to distinguish name, age, gender, and by 4 years they'll be able to tell us whether, like, a story or a rhyme. Last milestone which you need to know is social. In social, you need to know about 2 very important ones. One is going to be the second month. What you find is social smile. You'll see the babies mostly smile anytime when you see. Okay. By 3 months, they'll be able to know who is my mother. So that is known as mother regard. Now, guys, whatever milestone we're discussing, even if there is plus or minus 1 month, that is okay. But in these 2 conditions, social smile and mother regard, if this is delayed, then you will pakka say that there is delayed milestones. Okay, then there is delayed milestones. 6 months there will be stranger anxiety, and whenever they see a mirror, they will be able to smile at themselves. By 9 months they can play the game peekaboo, and they can also say bye bye. By 12 months they can play a simple ball game. By 3 years they will have a parallel play. What is parallel play, guys? Even though there is a group of people playing together, but they will be very like busy amongst themselves, and only alone they will play. That is parallel play. And by 4 years they will have group play, means playing together. Now these are the milestones which you guys need to know. I know it is a bit comparatively mugging up topics, so I did not waste too much time on this, but then I want you guys to revise this regularly. How you guys can revise this, I've explained in this part, day 0, 3, 7 and 21, is whenever you revise, like example, today you're revising, then after that revise it after 3 days, then 7 days, then 21 days. Like that, it's going to be, you will retain that information longer. Try to teach this to someone, so that it will be much more easier for you as well. Talking about our next system, that is going to be your nervous system. Okay, in our nervous system, what you have to remember is the neural tube defects. First of all, before studying about the neural tube defects, we need to know how is the neural tube formed. So you can see over here, first in between these 3 layers, the ectoderm, mesoderm, endoderm, you have a neuroectoderm. This neuroectoderm gets converted into a neural plate, and from the neural plate, it gets converted into a neural groove. This neural groove further goes deeper inside to form a semicircle. Around with that, on the top there will be neural crest, and finally a neural tube is formed. Now, what is a neural tube defect, guys? A neural tube defect is failure of the closure of the neural pore, based on whether the anterior neural pore is not closed, or the posterior neural pore is not closed. We are dividing it into 2 parts: a cranial entity and one will be caudal entity. Remember, caudal neural tube defects are much more common than cranial neural tube defects. Okay, let's start with talking about the caudal neural tube defects. Now, in caudal neural tube defects, you need to remember the most common which we know about is spina bifida, that everyone knows. Now, spina bifida has 2 parts. One is your spina bifida occulta, and one is spina bifida cystica. Spina bifida occulta and spina bifida cystica. What is the meaning of occulta, guys? Occulta means hidden. Okay, means it is hidden. Under what? We'll talk about that. Cystica means a fluid-filled face. So let's talk about the most common type, that is spina bifida occulta. So in this, they will ask you first, what is the most common location of spina bifida occulta? That is going to be S5 to L1. Okay, the hint behind this idea is that they will have a history of tuft of hair around the region or a lipoma. Tuft of hair around the region or lipoma. This is your spina bifida occulta. There will be no meninges or no spinal cord. The next condition which we have to talk about is spina bifida cystica. Now cystica means a fluid filled area that either now it can be having the meninges or it can even have the spinal cord. Based on what is there, we are naming it meningocele. Meningocele means this cyst area has only the meninges. What are the meninges here? 3 layers. That is dura mater, arachnoid and your pia mater. Correct? Meningomyelocele. The word myelocene means spinal cord. Now you guys know if this is my spinal cord and if there is any trauma to this part, every layer below this is going to get damaged, right? So that is why if there is meningomyelocele, there is increased risk of lower limb weakness and increased risk of rupture as well. This is spina bifida cystica. Next thing what you guys need to know is the cranial entities. Now the cranial entities are further divided into 2 parts. One is known as anencephaly. Anencephaly means A means absent, cephaly means brain, absent brain. Over here you can see the image. And the other condition is encephalocele. Encephalocele basically means a sac which is filled with the brain tissue and CSF. Okay, this is cranial neuropathy. Now failure or closure of anterior neuropathy, you can say by what day? Mention that in the comments. Okay, so this is also an anatomy question. What do you say in a cranial entity? A failure of closure of the anterior neuropathy by dash day. Okay, please answer. Now let's talk about what are the risk factors associated with why do a person basically suffer from NTD, right? First are the 4 most important. One, deficiency. What deficiency, guys? Folic acid deficiency. Then diabetes mellitus. What type of diabetes? A mother who is overt diabetes. Please be careful. Folic acid, like NTD defects, are most commonly seen in overt diabetes rather than gestational diabetes. What is the difference, guys? Gestational diabetes is that diabetes when a mother suffers from diabetes during her pregnancy, while overt diabetes is the mother was already diabetic before her pregnancy. So the mother who was already diabetic before her pregnancy is in increased risk of NTDs. Other third thing is drugs, especially anti-epileptics. In the anti-epileptics, you remember valproate is much more common of causing NTDs than carbamazepine. Last one is inheritance. They'll ask you what type of inheritance is your neural tube defect. That is going to be your multifactorial inheritance. Now the diagnosis. This is a PYQ question with respect to obstetrics, guys. They'll ask you which anomaly can be detected earliest by ultrasound. That is going to be your encephalocele, absent brain. Okay, anencephaly will be there, is the anomaly which will be detected as early. Okay, remember this. This is the PYQ detected earliest via ultrasound as early as 10 weeks. Okay. Now they will ask you what are the markers. The marker, if you see in general, which will be elevated, that is going to be AFP, that is alpha fetoprotein. But if they'll ask you which is the most specific marker which is elevated, then you have to answer acetylcholine esterase. Then you have to answer acetylcholine esterase. Okay. Talking about the prevention aspect, how do you prevent? The basic, if they'll ask you how do you prevent like this one of neural tube defect, your answer is going to be periconceptually. You have to give folic acid supplementation before pregnancy and along with that during pregnancy as well. Just a second. Come. Sure. Okay, so as I was saying, periconceptually you have to give the folic acid, that is going to be before the pregnancy, along with that even during the pregnancy as well. Now what is the dose? If there are no previous histories of such NTDs, you have to give 400 microgram of folic acid or 0.4 milligram, which is the same equivalent of the dose per day. But if there is a history of previous neural tube defect disorder, if patient is overt diabetes, if patient is on a history of anti-epileptics or any other problem, that time you have to give the 10 times the dose which is then normal. That is going to be now 4 milligram or 4000 microgram per day. Okay, remember, if the patient is diabetic, if the patient is and have a history of epilepsy and is on anti-epileptic drugs or previous history of NTD, you're going to give 4 milligram, not 0.4 milligram, 4 milligram and 4000 microgram. Okay. Next thing what you guys need to know is, if they'll ask you like this, what is the commonest cause in an infant having the following features? Okay, let's talk about it. Patient comes with you with a large head that also with a standard deviation of more than 2. If you see the head veins, the scalp veins are quite dilated. Another thing is, whenever you see your sclera, you are able to see the sclera from the lower part, but you're not able to see the upper part of the sclera in a normal person. But in this condition, you're able to see the upper part of the sclera. Why? Because of the increased ICT, intracranial pressure, the eyes have been rotated downwards, and this is known as sunset sign. What am I talking about, guys? This is congenital hydrocephalus. Now, what is the most common cause of congenital hydrocephalus, guys? That is going to be obstruction at what site? It is going to be at the aqueduct of Sylvius. Remember, guys, hydrocephalus is the most common cause of ventriculomegaly in the fetus as well. Okay, in the ventriculomegaly in the fetus as well. They'll ask you, what is the investigation of choice in case of congenital hydrocephalus? Answer is MRI, and the management is going to be VP shunt. Now, what is the full form of VP shunt? Guys, comment below. I want you guys to search. If those who do not know, search it out, because guys, passive study will never help you to retain longer. Whenever you search, whenever you stress your mind, whenever actively you apply, or whenever you're speaking, whenever I'm asking you to answer, just imagine this as a live session. That will really help you for your examination, and it will help you retain the information for much more longer time. Okay. Next topic, guys, we're going to talk about seizures and epilepsy. Now, seizures are of two types, okay? One is going to be generalized and one is going to be focal. The generalized type of seizures are of three types. One is going to be generalized tonic-clonic seizures, absence seizures, and myoclonic seizures, okay? While as focal seizures, based on if the patient was conscious or unconscious, is divided into focal aware and focal unaware, okay? In babies, in neonates, specifically in neonates, the most common type of seizure we find out is subtle seizures, which is because of like a brain development, lack of brain tissue development, because you guys know that the brain is developed in the first 2 years of life. So slowly, because of the brain grows, right? So some immature signals are passed away. That's why the patient is suffering from seizures. The important thing they will ask you is, what is the drug of choice of subtle seizures? That is going to be phenobarbital. Okay, that is going to be phenobarbitals. So in neonate, subtle seizures are there. Now, in older children, you have two types of seizures. One is going to be febrile seizures, and other is going to be absent seizures. Remember, febrile seizures are much more common than absent seizures. Now, let's differentiate among both of them. You need to know, guys, that the age group in which febrile seizures occur is by 6 months to 6 years of age. What is the description, guys? The child had a fever. Within 24 hours of fever, he suffered from seizures. What type of seizures, guys? GT, generalized tonic-clonic seizures. That also within 24 hours, and the duration of the seizure was only 15 minutes. Now, what will you do an EEG? First of all, what is the full form of EEG? Please comment on the comment below. Okay, you need to know, because they are really asking even the simple things. We try to go on the depth of information, and when we forget small things, right, they try to figure that. They want to trick you. They already know that you know a lot of information, but they want to trick you out. Okay, so I want to know the two full forms. Please comment in the comment below. One is, what is the full form of EEG, and second, a PYQ already has come before. What is the full form of fast scan? In trauma, when you do an ultrasound scan, right, the fast scan, what is the full form? Please comment below. Okay, remember, in febrile seizures, you don't require to do an EEG. Why? Because we already know this is a fever induced, and there will be no such abnormalities on the EEG. What is the treatment, guys? For the fever, we are going to give paracetamol, and to control the seizures, we'll be giving IV benzodiazepines. Okay, IV benzodiazepines. Now the mother will come to you and they'll tell you, will this happen again? How can I prevent this? You can prevent this is, if the baby who has a history already of febrile seizures, you can ask the mother to give paracetamol along with her oral clobazam and diazepam, in especially the first 3 days of fever. You'll give paracetamol and oral clobazam and diazepam at the first 3 days of fever. Okay. Now talking about, guys, absence seizures. In absence seizures, first you need to know what is the age group. It is school going age group. What will be the complaint from the teacher? They will be like, he's not paying attention, there is absent staring spells. Okay, the seizures which are there, they are multiple, so many seizures will be in a day, but the duration is very brief, around 15 to 30 seconds only. There is no post-ictal period. Okay, there is no post-ictal period. What is post-ictal period, guys? Basically, whenever there is a seizure or something like this, right, the patient does not know what is happening. He does not know what is happening around. He's like very irritated like that. But in this condition, for example, if I was like writing and all of a sudden I got a seizure, then I'll continue writing. I did not know this episode has ever happened, and I'm cool and everything is cool. Okay. Now, in this condition, you will do an EEG. In the EEG, you will find a characteristic feature, that is 3 Hz spike and wave pattern. They will ask you what is the treatment of absence seizure, guys. That is going to be valporate. Okay. If now in a similar condition, the question comes is ki now you have to answer, okay, what is like a patient comes with fever and seizures. Okay, so then that just now we treated about in case of febrile seizure. But in an 11-month-old child who was previously normal, we had their first episode of fever and seizures, which was GTCS. If there was no other complaint, guys, then you will treat them as febrile seizure. But you found out that there is bulging fontanelles. Now, guys, in a child like this, if you have fever, seizures and bulging fontanelles, that is because of meningitis. Meningitis will cause cerebral edema, which will cause inflammation and thereby having bulging fontanelles, right? So let's talk about meningitis, everyone. You need to know that in meningitis, the signs, which is nausea, vomiting, headache, you will not be able to elicit in babies, right? In children. So there are 3 signs which you need to know. One is neutral rigidity. So you will ask the child, or you will try to bend and ask the child to put the chin to the chest. Like how is it? They will not be able to do it. That is because of neutral rigidity. Now then there are 2 signs. One is Brudzinski sign and one is Kernig sign. How I remember Brudzinski sign is, see, in A, B, C, D, in within now 2 things we have. One is B and one is K. Remember the 2 letters. What comes first, guys? B comes first, right? So remember, in our cephalocaudal progression, there are 2 regions which these signs are going to happen. One is going to be in the neck region and another is going to be in knee region. So remember, B is first. So whatever happens related to the neck, that is a Brudzinski sign. So what is Brudzinski sign is, when we bend the neck, when we, B for Brudzinski, B for bend the neck, our knee gets flexed. That is Brudzinski sign. And K for Kernig sign and K for knee, when we flex the knee, there will be pain at the back. That is Kernig sign. Brudzinski sign is when we bend the neck, your knees will flex, and when you flex the knee, you will have low back pain. That is Kernig sign. Okay. Talking about the etiology of meningitis, overall bacteria is the more common cause than virus. If they'll ask you what is the most common bacteria which will be causing, that is going to be streptopneumonia. Okay, streptococcus pneumonia. Now, guys, streptococcus pneumonia is also known as another dash. So please comment below what is the also name, because they can also, in the options they'll ask most common cause of meningitis in children, and streptococcus pneumonia will not be there, but the other name will be there. So please answer that also in the comments below. Again, if you don't know, search for it, so that now once you search for it, right, it will be much more, you will retain it much more than right now if I would already given to you in the slide. Okay, if they'll ask you the virus, guys, worldwide the most common cause of viral viral meningitis, that is going to be enterovirus. In India, it is going to be Japanese encephalitis. And encephalitis is a different thing. We're talking about meningitis. So in meningitis, enterovirus, and in India, Japanese encephalitis. While if you talk about encephalitis, herpes is a common cause in case of encephalitis. Now, guys, talking about the CSF analysis, a very important topic. This comes in medicine also, this comes in PD also, a very important. So please pay attention to this. Okay. So guys, remember this fact. Okay. Normal, the CSF pressure is going to be 50 to 180 mm of water, not mercury, guys. 50 to 180 mm of water. Talking about the appearance, remember, normally it is going to be clear. Cells are going to be 0 to 5 lymphocytes. Protein is going to be 20 to 45 milligram per deciliter, and sugar is going to be 66% of the normal in the blood. This is the analysis of CSF. So in CSF, you're going to have how much sugar, guys? 40 to 70 milligram per deciliter. This you have to by heart. These are the values. Now let's talk about what are the values in case of bacteria, viral, and in TB. In bacteria, remember, in bacteria, viral, and TB, because of inflammation, CSF is going to be high. That is clear. Appearance in bacteria is going to be turbid. The cells will be neutrophils. That's also the neutrophils. Obviously, you remember in infection, neutrophils are always high, and it will be in the number of thousands. Okay, protein will be elevated. Why? Because of antibodies, and the sugar will be very low because bacteria needs to feed and they are attracted towards the sugar. The condition in the CSF in which the sugar is low, that is known as hypoglycorrhea. This is a PYQ, guys. So sugar is low, that is known as hypoglycorrhea. It can also be as low as 0. Okay, let's talk about viral, guys. In the viral one, you need to know CSF is high, appearance is going to be clear. Okay, cells are going to be elevated, that is going to be lymphocytes. Remember, guys, viral meningitis is also known as aseptic meningitis. Okay, viral meningitis is also known as aseptic meningitis. Why? Protein levels are going to be mildly increased or normal, and sugar, very important to differentiate this, sugar in viral meningitis is going to be normal because they don't feed on it, while as in bacterial and in TB the sugar is going to be low. All right, let's talk about TB now. Pressure elevated, appearance like bacterial will be turbid because of pus. Cells will be in bacterial it was neutrophils, over here it will be around hundreds, but lymphocytes. Viral and TB both will have lymphocytes. Protein will be so much elevated as compared to 2. Why? Because of increased amount of fibrinogen. When you do the test, you will find out that there will be a thing called cobweb coagulum. You will think what? Cobweb coagulum. That is because of increased fibrinogen. This is seen in TB. Sugar will be again low. So this is the CSF analysis, a very important topic. You guys should be very thorough with this. Okay. Next thing, guys, is the management. Remember, in bacterial meningitis, what you're going to do is you have to give antibiotics. The best is around the 3rd generation cephalosporins. Along with 3rd generation cephalosporins, we're going to give steroids. Now, there are 2 reasons why we're giving steroids, guys. One is to decrease the inflammation. Second is to improve the penetrating power of the drugs. Okay. The side effect of all these 3 infections of basically this meningitis is it can lead to sensory neural hearing loss, especially like something like Haemophilus influenza. That is why always get a BERA scan done for the child. So guys, this is part 5 for my side. I hope you guys understood this, and see you guys at the next part. Take care.